All right, so our next information is on the neuromuscular system and how it affects our pediatric patients. Some of these are the same things you've probably heard about in adults as well. So here's another one of those little cartoon type things, but it's also a spider map, concept map type of thing that breaks down increased intracranial pressure and how it affects the body and some of the assessments we are going to look for in treatments. And we will discuss a bunch of these things in the next few pages. So, cerebral dysfunction and assessing an increase in intracranial pressure in our children. It's usually in a subtle little signs in children. So we may hear of headaches, nausea and vomiting, vision changes of blurred or double vision. We may not see anything until they start having a seizure. We may even just see some personality or behavior changes, irritability, restlessness, or crying. Those are all signs of possible increased intracranial pressure. Have you seen a change in their school performance and it decreases? Are they unable to follow simple commands that they usually can do? Are we noticing fatigue and memory loss? Are they sleeping more? Are they lethargic? That inability to focus or concentrate, increased confusion. These could all be some of those signs we would notice in our pediatric patient. So, late signs of intracranial pressure would be decreased consciousness, decreased response to pain, having a 1 to 5 on your Glasgow Coma scale. So a changing in level of consciousness, it might be for a few days, for hours, or indefinitely. The decrease in motor and sensory responses, so not responding to painful stimuli. So, for instance, I do an IV on a child and there's no response, and that could be a huge indicator that I'm having some late signs of intracranial pressure. Those pupil changes, so increased size and decreased reactivity, fixed and dilated, like we see in this picture of this cat. That is an emergency. Doll's eyes. So remember, babies start with some doll's eyes, but that goes away pretty quickly. If we are able to rotate the head to one side or the other, and there's no movement of the eyes in the opposite direction to rotation, that could be a sign of changes. Posturing, decerebrate, and decorticate. If you don't remember what those are, look at your health assessment stuff. I also have a couple pictures for you. Elevated temperatures. Pulse and blood pressure changes. Though vital sign changes are significant, they tell when pressure is affecting involuntary centers of the brain. So rapid pulse, slow bounding, or feeble pulses. Changes in the pulse and blood pressure are more important than the actual change. Okay, so any kind of major change is more important than if it's too high or too low. There's no spontaneous movement, or there's asymmetrical movements. Typically with the respiratory system, it's slow, deep, and irregular. Periodic to irregular breathing. This is a good sign that it is some ICP. Once again, no response to those painful stimuli. You need to let somebody know right away. This is that Glasgow Coma scale. It should be very similar to what you've seen in health assessment. One thing to pay attention to is when we get to being over the age of 2 and under the age of 2, what we're looking for for response to auditory or visual stimuli varies depending on the age. So for our infants, we're looking for no response. They're crying. Are they smiling or following us? Things like that. Whereas our older kiddo, it's more like an adult. Are they oriented to where they're at? Or are they confused? What kind of words they're using? Is it inappropriate for what they are able to do? They're not talking at all. There's no visual stimuli. And then if I have an endotracheal tube or a trach, I need to mark that because I can't assess some of this. Okay, just like we do in those adult patients. So posturing. Decorticate. Okay, that's a severe dysfunction of the cerebral cortex. So that higher brain functioning is gone. That's that adduction of the arms at the shoulders, flexion of the arms on the chest. The wrists are flexed. The fists are clenched. The extension or adduction of the lower extremities. Okay, decerebate. That's mild dysfunction. That's your midbrain. You have rigid extension and pronation of the arms and the legs. We may only see this posturing when that child is stimulated with that painful stimuli. Typically, decorticate goes first because that's the cerebral cortex. Then you can see the decerebate, which is the midbrain, and that means it's bad because it's getting, we're progressing. The next thing that could happen is herniation of that brainstem. So here's a picture of decorticate and a picture of decerebate. Hopefully these are familiar to you. Here is also the breaking down, or another way to kind of, if you have trouble remembering, decorticate, decerebate. Okay. Okay, this chart is in your book. Very important for you to look at and be able to recognize the early signs versus the late signs. Okay. Some of these were like, I can't tell these in a baby's. Well, look at near the bottom. In infants, the early signs would see is the bulging tense fontanelles, those wide sutures, the increased head circumference, the dilated scalp veins, that high-pitched cry. Okay, so those are your early signs. And then your late signs are that decreased level of consciousness, changes in the motor and sensory responses, bradycardia, irregular respirations, and beginning to have chain stokes, the posturing, the fixed dilated pupils. You're going to see that again this semester. You're going to see it again next semester. So this would be a good thing to keep close to you and have somewhat memorized. So what can cause some increased intracranial pressure? Well, guess what? Bacterial meningitis is one of those. So we are going to hit all of these points through the next couple slides. So bacterial meningitis is an acute inflammation of the central nervous system, specifically at the meninges. This isn't as common now because of the HIV vaccine or the Hib vaccine. Okay. Causes of it, group B strep. So that's why we need to know if that mom's group B strep positive so we can get antibiotics to that baby stat. H. fluenzae, pneumococcal, Neisseria meningitis, or meningococcal, E. coli. Okay, more pathophys. It's usually a secondary infection, such as an ear infection in kids less than 5. That occurs first, and then it goes into bacterial meningitis. Cold, sore throats, upper respiratory infections, those things, if not treated or taken care of, can lead to bacterial meningitis. Organizations that may directly enter through a wound or procedure, so like a skull fracture, lumbar puncture, spina bifida, ventricular shunt, falling and cutting open your leg and getting it infected, things like that. We end up with inflammation of the meninges in the arachnoid space, and then it spreads to your cerebral spinal fluid. You have the bacterial infection, and then you have immune response that's going on. Inflammation worsens. You have inflammation and exudation. You end up having white blood cells that accumulate, and then you get tissue damage. You can also end up with ventricles that become occluded and obstructed by this thick cerebrospinal fluid because of all that inflammation and accumulation of the white blood cells. And then you get pus and fibrin and adhesions that occur and more edema. And then you end up with increased intracranial pressure. And what are the signs of increased intracranial pressure? Well, go look at that chart I just showed you. Okay, so this is an example of how you would do a spinal tap to get this cerebral spinal fluid. So as you look in this picture, this kid is on its side in the fetal position, and what's that doing is it's opening up the spinal tract and exposing it easier to the cerebral spinal fluid. You can also do the same thing and have the patient sitting up and over like a bedside table and things like that, and to get that back opened. Patients need to hold very still. Us as nurses, when we're holding infants and young children, we need to have a really good tight hold on them. We can use things for pain, such as that Elamax 4 or Emla type cream that numbs the area. We will use sucrose pacifiers for the babies, things like that as well. We don't typically just give pain meds, but we can do like a topical type of thing to help with the procedure. We can also use our distractions. Okay. So managing bacterial meningitis, this is typically considered a medical emergency, and these patients are in the ICU. They are isolated with droplet isolation until they're 24 hours post antibiotics. Their antibiotics are going to be by IV. We will also give them Tylenol or NSAIDs to help avoid shivering and fevers. These kids can be very, very sick, and they often die from bacterial meningitis if not treated correctly. We need to make sure we're doing good hydration, decreasing those signs of increased intracranial pressure, controlling their seizures because bacterial meningitis could lead to seizures, can control the seizures by doing anticonvulsants, maybe even like a phenobarb or pentobarb. However, I want to say phenobarb we're not using as much anymore. Some antibiotics that we will give, and we're going to start them as soon as possible, would be like a vancomycin or a rocephin, or a combination of the two. We're going to do anything we can to decrease stimulation. So no TVs, no Nintendos, which we don't really use Nintendos anymore, but no PlayStations, those kind of things. We're going to probably do intracranial pressure monitoring via CT scan or even a shunt. We're going to do neuro checks. So remember from back in health assessment what kind of things we do for neuro checks. For infants, we're going to be constantly checking their head circumference. We're going to make sure they're in that quiet environment, low noise, low lights, etc. They're going to end up having IV infusions, so we're going to monitor them closely for fluid overload. So once again, checking that head circumference, making sure we're not having too much fluid and having respiratory distress or going into hypervolemic shock. What do we do to protect a patient from meningitis? Our Hib vaccine, HIB vaccine, pneumococcal, meningococcal, that screen for group B strep in the pregnant women, and prophylaxis when we think somebody's been exposed. We also have encephalitis that can occur, which this is just an inflammation of the brain that may include the meninges. It's typically due to protozoals, bacterial, fungal, or viral invasion. And you're just going to have changes in your sensorium and focal neuro changes. What do? It's just supportive care. So so if they're having viral symptoms, we'll treat those. Treatment is related to prevention, basically. So keeping up to date on our immunizations. Vector control. So who is infecting us and getting rid of those. So like for instance, our mosquitoes. Insect repellents, things like that, so we don't have these bugs or exposures to these types of microorganisms. So Rey syndrome is toxic encephalopathy, and then there could be other organ involvement. Brain, the liver suffer the most. You can also have hepatopathy. These kids tend to have fever with severely impaired consciousness and a disordered liver function. What typically happens is these kids end up getting a viral infection. And what do we do to treat the viral infection? We treat the symptoms. But what some people end up doing is treating the symptoms with aspirin. And there's that link to treating these kids with aspirin and them developing Rey syndrome. Symptoms we need to watch for is vomiting, changes in their mental status, lethargy, hyperreflexia, confusion, and irritability. How do we diagnose it? We look for elevated ammonia levels, we look at their liver enzymes, and we're going to end up doing a liver biopsy. Manage is extremely important for these guys. We're going to do aggressive therapy. It's treated as a medical emergency. It can turn to a coma very quickly. Mortality can be close to 40%. So what ends up happening is these kids end up with cerebral edema and that increased intracranial pressure. So to decrease that intracranial pressure, we're going to give mannitol to help with the decrease in swelling, or we may end up draining cerebrospinal fluid. We're going to protect the brain against irreversible damage by decreasing that swelling, because if we have lots of swelling, what ends up happening is there's damage to the brain. Okay, if we can decrease damage to the brain, these kids can recover completely. These guys can get dehydrated pretty quickly as well, so fluid and electrolyte balances could be off, so we want to make sure we're managing their fluids. So to prevent it is, once again, relating education to not giving aspirins or aspirin-containing products to our pediatric population. We never know when they are going to have a viral illness, and there's that connection with treating that with aspirin. So things aspirin are in: Alka-Seltzer, Pepto-Bismol, Midol. I'm trying to think. There's a bunch of other stuff. Think of those non-common things and have the parents look for those. And make sure, just stay away from aspirin in general. All right, you guys should be able to answer this question. Okay, another thing we're going to look at is seizure disorders. And these will be the big things we are going to discuss in the next few chapters. I'm hoping you guys have hit on seizure disorders in the adult population as well. So you can kind of compare and contrast, and some of this hopefully will be review. So we have acute or chronic seizure disorders. So chronic would be like epilepsy. Etiology of acute would be a rapid increase in that body temperature, the infectious diseases, trauma, metabolic disorders due to fluid and electrolytes, vascular disorders, tumors, and hypertension in pregnancy. With a seizure disorder, you're having a brief malfunctioning of the brain's electrical system resulting from cortical neuronal discharge. So you could have unconsciousness, altered consciousness, involuntary movement, changes in their perception, behavior, sensation, and posture. Etiology of epilepsy. We don't know. It's idiopathic, unknown cause. We think there's a correlation with genetics. Acquired results, epilepsy is a result of a brain insults, that head trauma, severe hypoxia, infections, or toxins. Cerebral palsy, they think, could be if a patient has cerebral palsy due to the results of brain injury or congenital birth defects, then they've seen a correlation with them of having epilepsy as well. Some kids will end up having febrile seizures. It's transient, generalized, tonic-clonic type of seizure. It usually only affects about 4% of children that have a fever. It usually occurs after the age of 6 and up to the age of 3. They should not last longer than 15 minutes. They have that the occurrence with that rapidly rising temperature. What's the concern is that severity of the height of the temperature, not how fast it's raising. Usually these kids are going to be greater than 102.2. Antipyretics will not prevent the seizure. What ends up happening is after the seizure, the hypothalamus resets, and then that helps drop that seizure or that temperature. Kids with known febrile seizures will get Tylenol and ibuprofen when they're ill. They don't typically get anti-epileptic meds. It's benign. However, we do teach parents that if it lasts longer than 5 minutes, go ahead and call a doctor. They wonder if there is an increased risk for epilepsy for kids that are having these seizure disorders. However, the last I heard, there's no definite on that. So pathophys of seizures, you have that increased electrical excitability in response to those variety of physiologic stimuli, electrolyte imbalances, fatigue, endocrine changes. Some things that you've probably heard related to seizures or that is that aura, and that patient ends up seeing something or feeling something and knows that seizure is going to happen. The postictal state is after a seizure. This occurs as the neurons realign and the body recovers motor function. These kids can be in the postictal state for like 24 hours. They're relaxing, they're semi-conscious, but difficult to arouse, confused for hours, they have poor coordination. Their feelings or behaviors show signs of confusion. They're not able to speak. They may have amnesia. They may have headaches or sleepiness. Status epilepticus is that series of seizures at intervals too brief to allow the child to regain consciousness between one another. This is an emergency. It leads to that child getting extremely exhausted. If they last over 30 minutes, these kids end up having brain cells that die. They have decreased respiratory rate and could lead to death. So we need to stop these seizures. So we have partial or focal seizures. This involves a limited area of the brain. There's simple motor sensory manifestations to bizarre reactions. So simple would be numbness, tingling, pricking, pain starting in one area like the face or the extremities, and then it spreads. There's visual sensations, tonic-clonic movement, no alteration in their consciousness, no memory of the event starting. They also will have times when they just stare off into space. They usually last about 10 to 20 seconds. Then you have those complex seizures that may begin with that aura. They may become unconscious or have altered behavior, complex, purposeful movements, amnesia, and no response to their environment. You have bilateral and symmetric, no point of origin in the brain, and travel the entire brain, both hemispheres, no focal onsets. You have absence. This is a brief loss of consciousness that lasts less than 30 seconds, little change in behavior, abrupt onset, mistaken for daydreaming, inattentiveness, or minor movement, like a twitch of the eyes, lip smacking. They typically have amnesia for the episode. You have atonic, which is those drop attacks, sudden loss of muscle tone, they fall to the floor violently, and they can't break their fall. Very possible that they could have serious injuries due to this, and momentary level loss of consciousness. Tonic-clonic, or the used to be known as grand mal. There's usually an aura, loss of consciousness. Most common we'll see like that with the tonic part is those eyes roll up, and then they have immediate loss of consciousness, fall to the floor, stiffen, and the entire body in that tonic contraction like you can see in this picture. The arms flex and they become apneic. Then they go in the clonic part where they're violently jerking, foaming at the mouth, and have a period of incontinence. So what do we do when our patient has a seizure? Well, one of our biggest things is, besides protecting the patient, is getting a good record of what's going on. But they say you should document and not do anything unless there is reason to that the patient's going to harm themselves, and you need to do that first. So what do we need to do? We need to describe the seizure. So it needs to be complete, accurate, and detailed. Was there an aura? Was there motor changes? How did it progress? The duration? Were there changes in the color? Vital signs? Were there apnea? Were there those eye movements? Muscle contractions? What was the consciousness like? Do they go in to that postictal state? And then we need to protect them from injury. So if they're standing up, get them down to the ground. You may put them on the side. You may give them O2 if they're cyanotic. We also need to make sure we're giving their meds with meals or at bedtimes. We typically do tablet over liquid. However, we do sometimes have to do liquid form. You can crush these pills and put them in food. One thing to remember, if you're giving phenytonin or dilantin, you're not supposed to give it with food or other drugs because it can decrease the effectiveness of it. These kids also need to make sure they have good vitamin D and folic acid. So we need to know what the triggering events were, so having that good history, so we can find a pattern. We can also then, if we know what the triggers are, we can then identify them and maybe stop things before it occurs. Is there changes in the dark and light pattern, camera flashes, reflections to light in the water, strobe lights, video games, and the flashing of the lights? Loud noises, sudden movements, or startling? Did we have a huge change in the temperature? Are they fatigued or dehydrated? Is there caffeine involved? Do they have enough protein and therefore they're not maybe metabolizing their meds because they don't have enough protein. History is extremely important so that we can narrow down like which part of the brain that could be affected and make sure we're giving them the right medications. So pharmacological management, that's the primary therapy. We want to make sure we control or decrease the frequency, find that correct cause, and get them to a normal life as possible. So their meds, what they do is they control the movement of electrolytes across the neuronal membranes, or things that are affecting neurotransmitter balance. So you can have an influx of sodium or calcium into the neurons, which enhances neuronal activity. Influx of chloride ion suppresses neuronal activity. Now, I'm hoping you've heard of these meds before. I'm just going to give a little bit of a brief overview. If you guys need more information, let me know. So, GABA. So we have our barbiturates, such as phenobarbital. It's a CNS depressant. It's once a day, typically. We have benzodiazepines, like Valium or Ativan, which would be a diazepam. This is for breakthrough. What are our risk factors when giving Valium or Ativan? So what happens to the respiratory drive? Side effects. What happens with diazepam or Valium that we need to look at? We also have phenytonin or valproic acid. These drugs suppress sodium ion influx across that neuronal membrane. So suppressing the influx of those positive ions suppresses the neuronal action potential. Therefore, there's no firing. And then that suppresses abnormal foci that are occurring. Remember not to give Dilantin or phenytonin with milk or other drugs because it interacts with many meds and it can make things less effective. What are the signs and the side effects of Dilantin? And then we have valproic acid or depakine. What are the side effects of that, and what can it lead to with your hepatic system? With the pharmacological management of Tegretol, dose is determined by monitoring the drug levels. So as that child grows, we're going to probably have to increase the dose. And then if they have no seizure activity in 2 years, they may begin to slowly withdraw the medication. And this will all depend on why and where the seizures originated. So we'll also look at EEGs. And then they'll slowly wean it off over a 1 to 2 week period and see if it continues to occur. When a patient is in status epilepticus, we're going to give Ativan. That is our drug of choice. These kids are also going to be on a ketogenic diet, which is high fat, low carbs, and possibly low protein. They're very closely monitored because these kids end up spilling ketones from fat metabolism, and that alters their brain chemistry. So we need to be aware of those things. This is a nice little cartoon and kind of explains what some of these meds do to the brain and things to watch for. Here's a nice little cartoon on Tegretol. Okay, and these questions, if you need the answers, just let me know and I will be happy to answer all of these. All right, and we're done.